So we have a question. A 28 years old male with no prior cardiopulmonary disease underwent short general anesthesia for septoplasty. Immediately after the extubation, he develops inspiratory stridor and makes forceful inspiratory effort against a closed glottis. Within minutes, he becomes hypoxic and expectorates copious pink frothy septum. Chest auscultation reveals bilateral crepitation. Which of the following statement regarding the pathophysiology of negative pressure pulmonary edema is most accurate? So we have understand that this is a case of negative pressure pulmonary edema. Now understand this. Whenever you have negative pressure pulmonary edema, remember this mnemonic noise where N is for negative pressure pulmonary edema, O is for obstruction, and I is for inspiration. So remember, for negative pressure pulmonary edema, always two things are very much required. First is the obstruction, especially upper airway obstruction, for example, laryngospasm, and patient has to inspire against the forced closed glottis. That means there is an obstruction and patient is taking inspiration, forceful inspiration. These two things are very much required. Then only negative pressure pulmonary edema is developed. And from S, remember spasm, and mainly it is the laryngospasm, and most commonly after extubation this happens. And E is for epiglottitis or external substance that foreign body. These also happen, but less chances. Now, please remember a normal pressure, the normal intrathoracic pressure is around minus 5 centimeter of water, and especially during the inspiration, and it takes the blood from the lower limb into the thoracic cavity. But during forceful inspiration, during closed glottis, this pressure becomes minus 50 to minus 100 centimeter of water. So most important pathology is, it is because of the increased venous return. When the negative pressure becomes so much, there is high negative pressure into the thorax, which what does it causes? It sucks the blood into the thorax, and thus the pulmonary blood volume increases, and there is increased pulmonary capillary hydrostatic pressure, and there is increased accumulation of water in the alveoli, leading to the pulmonary edema, which is called as negative pressure pulmonary edema. Then there is also secondary pathology, that because there is a increased pressure that has been generated into the thorax, that is transmitted to the heart, and thus there is a more resistance against which heart has to pump. So that leads to a left ventricle has to work harder, and therefore left ventricle output transiently decreases. This is secondary pathology. And there is also one of the minor pathology, that it is said, most of the books write that because of this mechanical stress, because patient is forcefully taking inspiration against the closed glottis, and there is hypoxia, there is capillary permeability increases, and that also leads to the negative pressure pulmonary edema. Now, if I see the question, so what will be the